let us go to Chris, Boston, Massachusetts. That's the great WRKO country. How are you, my friend?
Good. How are you tonight, Mark?
Very well, sir.
It's always a pleasure to get a chance to speak with you, and love your show. So I'm a doctor here in Massachusetts, and I've called in before. I'm starting a company. I'm a surgeon in training, and it blows my mind that people are not aware of what this bill is actually doing from the inside out of the healthcare system. We're watching on our side now. We are so burdened by the information technology guidelines that are being imposed on the system, and I'm essentially going to probably call a collapse of this in a year, in October 2014, when we have to upgrade to the ICD-10 billing codes, which people aren't aware of.
Well, slow down, Doc. We don't know this stuff. Just go slowly.
Sure.
What do you mean 10 billing codes?
So currently right now, the way we classify diagnoses and procedures to get a bill from the insurance companies, we use a classification system called ICD-9. Europe has been using the upgraded version called ICD-10, and what it does is it expands the number of codes and detail that you have to provide in order for an insurance company to know what you diagnosed and then what procedure you did to cut a check to.
All right, so why do you need, why is the federal government mandating software and data collection of that sort?
Well, so it's not just the ICD-10, but it's the meaningful use standards, which is something that was in the Affordable Care Act that requires all hospitals to be on medical records and meet certain requirements, or else they start to get penalties imposed on them. And there are deadlines coming up in the next year.
All right, well, slow down. So there's certain legal requirements for how you collect information, what you collect.
Correct.
And does the federal government have access to all of this?
That's the intent, is that this will feed into the federal government's reporting that hospitals will provide to them in order to standardize. And it makes sense on the surface. That
all right, hold on now. So I just want to slow down here. So if I'm a patient in a hospital and I have heart surgery or whatever it is, does my name go into this system?
So in theory, yes. It's in the process of getting set up, but a lot
Okay, so hold on now. So my name goes into the system. The problem I had goes into the system. The treatment I had goes into the system. Is that correct?
Yes.
And who has access to this system? HHS?
Yes. Yeah, exactly. And the idea is, on the surface, again, it's being sold to compare hospitals and providers, which, again, makes sense.
I don't give a damn how it's being sold. It makes sense, what? That the government collects more and more information on citizens who are using the healthcare system?
No, I don't like that part. That's
Chris, hold on, doctor. Don't hang up. I want to get into this a little bit more deeply. Yes, ladies and gentlemen, government's going to know everything. Everything about you. Not just your financial situation, but your physical and mental situation. And we have a doctor from Boston, WRKO country, with us, Chris. And I was talking with Chris. How you doing, Chris?
Good. Good, and you?
Good, and I want to walk through this now. I mean, there are other aspects we can talk about either later or another time, but
sure.
I'm focusing on this. The data collection information. Mm-hmm. They're trying to dictate what kind of software you use, what kind of information you put in, and I'm asking you as a patient or as a would-be patient, all the information you would put in on me. Let's say you're my cardiologist, the treadmill, with the sonogram, the medicines I'm taking, this, that, and the other, the various monitors and so forth, and all the rest. You put it into the system. Where does that information go?
So it starts by going into a hospital database, and then the government's requiring that certain elements of that information, and it varies by the condition or the specialty, gets reported out. And eventually what that will feed into is the health exchanges, where they're going to try and match you based on your condition, your risk profile, to the type of insurance you're supposed to have. And that's what people miss with the health exchanges, is that it's not exactly a Priceline.com. It's supposed to match you to the type of insurance that will best.
All right, so the government, in one form or another, collects this information on Mark Levin or Ernie Grabotsky or Sarah Smith or whomever. They collect the information, and then they try and match us with the healthcare program or policy they think I should have?
Yeah, but that's the idea, is that eventually when the exchanges are up and running, they're going to determine, essentially it's risk pooling, and this hasn't been spelled out, but when you see how these IT guidelines are being rolled out, that's where it's directly headed, because they want to know who's got what, who's going to require how much healthcare, or what the resources are going to be required to take care of more sick people, and then they're going to direct you to insurance. But
well, you say direct me. What if I don't want to use that particular insurance and I want to use different insurance?
Well, that's what's kind of confusing about all this. They're saying that the private insurers are going to be listed on there as well, and so ideally, if you want to buy a better plan, you could buy that other plan. But they're going to be astronomical in cost because of what they're being told they have to include for free, and that gets into all these other parameters for free cancer screening.
All right, so let me slow you down. So the government's basically writing these policies for these private companies, correct?
Yes.
They're writing these policies for these private companies. You're inputting data on me. I've been at your hospital. So they are linking up the data they require you to put into your system to the policy they require the insurance companies to design. And then the government tells me what I qualify for, correct?
That's what will eventually be the plan, yes.
Well, why do I need all of that crap? Why do I... bureaucrats are going to know better than I what kind of policy I need?
Exactly, and when you should or shouldn't get the procedure that the doctor thinks you should have. And
that's the next point, isn't it, doctor? So they have my information. They know what kind of insurance plan I'm on. They designed it. And the next thing is they get to decide at some point what I can and cannot have. Correct?
Yep, and that's what they're essentially doing in the VA. And the best example is knee or hip replacements, and where they look at the particular veteran and say, well, you are too young, and your knee replacement only has a shelf life once it's surgically placed for 10, 15 years. You're not going to be old enough yet, and we don't want to give you a second one, so you're going to have to wait.
All right, so wait a minute. So if you're too young, you can't get one, and if you're too old, you can't get one.
Correct. It's based on the utility of the expense of that particular procedure, how long it's going to last you, and that...
Stop right there. It's based on the utility of the expense to the government.
Correct.
Whereas if it were private, it would be based on the utility of the expense to me, which would be a very high priority.
Correct. Absolutely, because that's your quality of life is impaired, but that doesn't exactly get factored in here. And, either way, although they say that that's not going to happen directly, that is what's going to happen because there's going to be limited money. So, and the worst part about this is
there's going to be rationing and price controls. Otherwise, why all the control in the first place?
Well, if they had paid attention to what happened in England, which is now shifting more private, much like our free system used to be, our market-driven system used to be, they would realize that it doesn't exactly work, particularly in a country...
They don't care, doctor. They know it doesn't work. They don't care. Right. What they've managed to do now is we have to grovel at the feet of the politicians and at the feet of the bureaucrats and the bureaucracy to get our health care.
Right. And I think what frustrates me is that patients just don't realize that's happening. And we're already seeing it in the hospital. We're seeing volumes of procedures going down. The costs are too high, and the co-pays are too high for patients to get the surgeries we need. We see it with, more in my area, bariatric surgery, various laparoscopic procedures for weight loss and things like that, where patients can't come to given hospitals because now they're priced too high.
Let me slow you down. What's priced too high?
So the procedure will have the hospital say it's $45,000 is our cost for a gastric bypass, for example. But the insurance companies, because of the costs now that are going up, have to say that you're going to have to pay more out of pocket to cover that procedure. And
they're saying that because the government has said, look, you're paying for free prescriptions, you're paying for free contraceptives. You're covering kids up to 26. You have no caps. You have this, you have that. And the government will keep doing that, by the way, on different aspects of it. And so the insurance company's looking at their spreadsheet, and they're saying, okay, we can't afford to pay XYZ anymore of ABC.
Absolutely. And more importantly, what's happening, we're seeing now, is that certain hospitals, they'll say, well, if you want to go to that hospital, it'll be $10,000 out of pocket. If you want to go to this hospital, it'll be $3,000 out of pocket. But the hospital...
Why is that?
Well, they're based on, again, the data coming out of each hospital, and if the insurance companies and the government feel that hospital is doing in a more efficient care, so they really can direct you to where they want you to go, where they think you're going to get the lowest cost or they say highest quality procedure, but you can't really shop around as easily as you'd like because you may not be able to afford a $10,000 copay.
Can you imagine people sitting down and thinking all this stuff up? Sitting there saying, you know what, I control the world. I'm going to build a puzzle, and this is how this is going to work, and this is how this is going to work, and this is how this is... it's just incredible to me. And what amazes me, and you know this, doctor, these politicians who voted for it, The politician who signed it, Obama, the politician who's the Chief Justice of the Supreme Court who voted for it, they never read this law. They couldn't have read this law.
No, and I downloaded it, and I can't claim I've read all 2,700 pages. I get too nauseous by the time I get through it. But
it's even more than that. You downloaded 2,700 pages, but it refers you to other laws and other information that you don't have in those 2,700 pages. I just looked through it.
Yeah, they're placeholders for opportunity to expand, which is what they're doing now. And if people watch, you can go on the CMS and HHS websites and see how many new guidelines come out every week, and they're astronomical, and they are expensive, and they're not logical because they're college kids that are in HHS writing these things. They're not providers who are in the system living this and making logical decisions about this, because these things have massive impacts on my day-to-day ability to care for you. And we're watching it now. We just don't have time to see people. We can't go see them and sit at the bedside and explain things as much because we have so many other stressors coming out of this bill now already. And this thing hasn't even come online yet fully. It's not even 2014 yet. So it's I don't think people realize there's going to be a big collapse in a year because the requirements are so expensive that hospitals are having trouble paying for them. They're not going to be able to implement them on the deadlines. And that there's that October 2014 when these ICD-10 billing and procedure codes come out, that HHS put out an email a couple weeks ago. I have to dig it up. They said hospitals should start saving up in a savings account enough operating revenue to cover them for several months after the implementation of ICD-10 because they're not going to be able to get a reimbursement back because they're going to be coding wrong because it's so challenging to appropriately create a bill to send to an insurance company. I mean, what hospital can save up 3-4 months of operating revenue? You run a 0.1% margin as is. So
Doctor, have you ever heard of a navigator?
I don't believe so.
Listen to this from the Washington Examiner. Great reporter Paul Bedard. Tens of thousands of healthcare professionals, union workers, and community activists, by the way, hired as navigators to help Americans choose Obamacare options starting October 1, can earn $20 an hour or more, up to $48 an hour, according to new regulations issued yesterday.
They should put that back in and pay the providers to actually take better care.
No. This is how Obama's going to fund his community activists and everything else. It even says community activists are among those who are going to get this money. 63-page rule covering navigators, drawn up by the Centers for Medicare and Medicaid Services. Also said the government will provide free translators for those not fluent in English, no matter what their native language is. The rules also address conflict of interest and other potential issues that navigators could face as the public's first stop. They're going to hire tens of thousands of people. They're going to pay them $20 to $48 an hour, including community activists who have as their goal to bring more and more people into the system. Let me ask you something, Doctor. Do you see more and more doctors coming into the system?
No, significantly less. And I've seen, I don't know how many surgeons retire in the past 6 months that are at the prime of their career because they've either been sued too many times or they just are getting too much pressure in the hospital. They can't operate enough. And I think the last one I saw that left that was a shame said, I've been sued one too many times in cases that I wasn't even directly involved, got dragged into court, my name was slandered. And now I can't even be in the operating room where I do my best work, where I want to be, because I'm outside dealing with paperwork and computers. And
so we don't have tort reform. So the slip and fall lawyers are going to run amok. The community activists get a piece of the action because they're going to be paid a fortune to drag more and more of their buddies into the system. The politicians will continue to impose requirements on insurance companies based on political pandering, which you and I will wind up paying for. They're going to put the squeeze on the hospitals, the squeeze on doctors, nurses, that is, providers. This is a complete disaster, absolute disaster. What happens when we bring all these people into the system and we don't have enough doctors?
Well, you get queuing. You get waiting lines, just like you see in Canada and England, and not even just for the elective things like knee replacements and things, but potentially more serious things like cancer treatments, where you get diagnosed with the cancer, you would want to start chemo, radiation, or what have you as soon as possible because you now know there's a cancer side of you, and they're going to say you have to wait 2 months to start because we can't afford where's that hospital or that cancer place?
Or they're going to drop it all together. They claim the sequester. They're starting to drop senior citizens and Medicare from oncologists. They're having to drop them because they're not being reimbursed. And we have the VA as a perfect example. As I read that there's like a 900,000 person backup. The average wait's over 200 days. These are men and women who served in the military.
Yep. Well, I have a family member who works in the VA system, and I trained in the VA system in medical school, and they're trying to I've seen several articles out where they're trying to force the veterans out of the VA system and into whatever we're going to end up with as our new system. And if you look at how the exchange is going to be set up, I can almost guarantee no matter what you put in, the plan that's going to be the most effective or cost-effective on top is going to be a government system. And eventually they're going to just price out the insurance companies, and they're going to get shut down. And this is all structured to get us on a fully nationalized system where we just can't possibly afford it, because where's the revenue going to come from?
Yeah, and this has been predicted from day one, that this entire Rube Goldberg operation is intended to squeeze off various life-giving veins to one part of the private healthcare system or another, and stampede us all into a federal top-down authoritarian system, price controls, redistribution of wealth, healthcare dislocation, just the entire disastrous mess, and it'll be so big, so ubiquitous, that it will run down the people. The people will get worn out trying to deal with it, And the sad part is, doctor, the sicker you are, the more ill you are, the worse your disease, the more rare your disease, the more difficult it's going to be to deal with this top-down government bureaucracy.
Well, there's going to be fewer centers to go to for your complex illness because they're going to have to close, and they're trying to regionalize. So they want fewer centers providing certain things because it's more cost-effective, quote-unquote, to have only a few centers in a given state that can provide that higher level, more expensive care. So they want to regionalize. So you could be at the other end of the state, 8-hour drive away, but you can only get your cancer care in New York City, but you might live in Syracuse. And that's an extreme example.
I love this talk about the government and cost-effective. I mean, that's like the mob running the FBI, Well, Dr. Chris, listen, I've got to run. You've been extremely edifying. You'll call again, right?
Absolutely. You bet. Absolutely.
All right. Great pleasure. There goes Dr. Chris from Boston, WRKO country. He's very, very helpful. We have another doc on the line. I'm going to get to him in a moment.